Good evening, Dr. Phil here. Today we'll be discussing on synthetic opioids part 2. Introduction. Synthetic opioids contain the phenanthrene nucleus of morphine and are manufactured by chemical synthesis rather than modification of morphine. Opioid classification, pharmacokinetics, receptors and pharmacodynamics has been discussed in previous videos. Topics such as pharmacokinetic values, opioid receptor distribution, and use of opioids in patients with renal failure has been discussed in these videos. Pethidine. This is a phenylpiperidine opioid agonist at MOP and KOP receptors developed in Germany in 1939. Routes of administration: oral, IV, IM. Metabolism occurs in the liver. Metabolism is extensive. 90% of pethidine initially undergoes demethylation to norpethidine and hydrolysis to pethidinic acid. Metabolism is reduced by cytochrome P450 enzyme inhibitors and increased by cytochrome enzyme inducers. Norpethidine is produced from pethidine metabolism in the liver. It is a CNS stimulant and is a convulsant. It is excreted in the urine. It has a half-life of 15 hours. Its clearance is significantly reduced in hepatic and renal disease. To avoid norpethidine accumulation, avoid prolonged, such as more than 3 days, repeated or high-dose pethidine. Pethidine should be avoided in patients with renal or hepatic impairment. Excretion. Pethidine is mainly excreted in the urine. Pethidine has a pKa of 8.5, protein binding of 70%, octanol water partition coefficient 39, clearance of 8 to 18 mL per kg per minute, volume of distribution 3 to 5 liters per kg, terminal half-life 3 to 5 hours, duration of action 2 to 4 hours. Onset of action 3 to 6 minutes with a peak effect at 6 to 7 minutes. Non-opioid activity of pethidine includes anticholinergic actions. Pethidine is related structurally to atropine, which explains its anticholinergic actions such as tachycardia, dry mouth, and mydriasis. Myocardial depression occurs at high doses of pethidine. Pethidine has antispasmodic actions. It relaxes bronchial and vascular smooth muscle. Pethidine may cause histamine release. Pethidine is a membrane stabilizer and has local anesthetic effects. Pethidine can attenuate or abolish anesthesia-induced postoperative shivering, probably via KOP agonism. Uses of pethidine. For treatment of acute pain, 50 to 150 mg orally or 25 to 50 mg IV 4 hourly. Treatment of labor pain, 50 to 150 mg IM, maximum 400 mg per day. To attenuate or abolish anesthesia-induced shivering, IV 25 mg. Pethidine compared to morphine. Pethidine is 1/10 as potent as morphine. It produces pharmacological effects that are very similar to that of morphine, except that it tends to cause restlessness rather than sedation, and it does not cause pupillary constriction. Pethidine has a similar duration of action with morphine. Pethidine is regarded by some as an alternative opioid in patients who are intolerant of morphine. However, there are no evidence that pethidine provides any advantage over morphine. Pethidine can produce similar euphoric effects as morphine and is liable to cause addiction. Metabolism of pethidine produces a hallucinogenic and convulsant metabolite norpethidine, which is not produced during morphine metabolism. Pethidine does not reduce the force of uterine contractions and is thus preferred to morphine for labor analgesia. Elimination of morphine is more prolonged than pethidine in neonates as conjugation reactions needed to excrete morphine metabolites are deficient in neonates. Pethidine is not given by subarachnoid injection due to high incidence of nausea vomiting. Interactions with MAO inhibitors. Increased norpethidine formation can occur when pethidine is administered in patients who are receiving monoamine oxidase inhibitors, potentially resulting in excitement, convulsions, hyperthermia. It is probably due to inhibition of an alternative metabolic pathway for norpethidine formation. Methadone. Methadone is a diphenylpropylamine formulated as a racematic mixture of R and S enantiomeric forms. It is formulated in 1947. It has a pKa of 8.3, protein binding 90%, Octanol water partition coefficient 26 to 57. Clearance is 2 ml per kg per minute. Volume of distribution is 5 liters per kg. Terminal half-life 15 to 20 hours. Duration of action 4 to 8 hours. Routes of administration. Methadone is administered orally or IV. It has a very good oral bioavailability of 60 to 95%. Oral to parenteral ratio is 1 to 2. Metabolism. Methadone is extensively metabolized by CYP2B6 in the liver to inactive metabolites such as EDDP. CYP inducers or inhibitors dramatically change methadone's elimination kinetics. CYP2B6 is affected by pharmacogenetic variability, thus there is considerable variations among recipients in the response to the drug. Many patient deaths has been attributed to long and unpredictable duration of action of methadone when administered orally. Excretion. 30% of metabolites are found in the feces, 60% are found in the urine at 24 hours, which consists of 33% methadone, 43% EDDP, 10% EMDP, and small amounts of other metabolites. Plasma half-life ranges 3 to 50 hours, averages 24 hours. Long half-life of methadone occurs as the drug is bound to the extravascular compartment and is slowly released. Plasma concentrations of methadone can be reduced by CYP450 inducers. Actions of methadone. Methadone acts by MOP receptor agonism, NMDA receptor antagonism, serotonin receptor antagonism, and blockade of potassium channels. Activation of the NMDA receptor is implicated in central sensitization in a variety of pain states. Thus, methadone is useful for reducing opioid tolerance, reducing opioid-induced hyperalgesia, treating chronic pain states related to pain hypersensitivity, and treating neuropathic pain. Onset of action of methadone, 0.5 to 1 hour after oral administration. Peak effects occur in 1 to 7.5 hours. Duration of analgesic action, single dose, 4 to 8 hours. Repeat dosing, 22 to 48 hours. Uses. Methadone is used for treatment of chronic pain due to its long duration of action. The dose is 5 to 10 mg orally, IM or subcutaneously, TDS or QID, or BD in chronic use. Methadone is used for opioid maintenance in opioid addicts. Methadone's long half-life causes attenuated physical withdrawal symptoms, but not necessarily psychological withdrawal symptoms. Heroin addicts are given regular oral methadone to help them wean off their addiction to heroin. Methadone has been used to suppress cough in palliative care. Adverse effects of methadone: as morphine but milder with less sedation and is less euphoric. Accumulation of methadone can occur with repeated dosing. Careful monitoring is essential when converting patients to long-term methadone. The S form may be responsible for QTC prolongation. Incomplete cross-tolerance exists between methadone and morphine, as the racemic methadone mixture in common use has agonist actions at the MOP receptor, mainly via the LEVO isomer, and antagonist activity at the NMDA receptor, mainly by the dextro isomer. Tramadol. Tramadol is introduced in the UK in 1994. It does not fit in the standard opioid structural classes. Tramadol consists of a racemic mixture of R-dextroenantiomers and S-levoenantiomers. R-dextroenantiomers has low initial activity at MOP receptors as an agonist. Its main metabolite, O-desmethyltramadol, has high MOP receptor affinity and results in a 6-fold increase in analgesic potency. R-dextroenantiomers inhibits the reuptake of serotonin within the central nervous system. Sinister levoenantiomers mainly inhibits the reuptake of noradrenaline within the central nervous system. Available preparations: oral, immediate release, or sustained release. Tramadol is well absorbed orally with oral absorption of 100%. Oral bioavailability is 70% for the initial dose due to first-pass metabolism and increases to 90 to 100% after multiple oral dosing due to saturated first-pass hepatic metabolism. Parenteral preparations also exist. Metabolism of tramadol. Tramadol is metabolized in the liver via N and O demethylation and conjugation of O-demethylated compounds. CYP2D6 and CYP3A4 enzymes are significantly involved in the metabolism of tramadol. Alterations of tramadol pharmacokinetics is seen in populations with varied amounts of CYP2D6 activity. 23 metabolites have been identified in humans. The main metabolite is orthodesmethyltramadol, which has a high MOP receptor affinity as mentioned. Excretion. 90% of metabolites are excreted renally, the rest is excreted in the bowel and feces. Protein binding 20%. Time to peak plasma concentration for oral immediate release 1.6 to 1.9 hours. For oral extended release formulation 12 hours. Half-life is 4 to 6 hours. Mechanism of action of analgesia caused by tramadol. Tramadol causes analgesia via MOP and KOP receptor agonism. Most of tramadol's analgesic effects is mediated by O-desmethyltramadol, a metabolite of tramadol that has a 200 times higher affinity for the MOP receptor than tramadol. Tramadol is 5 to 10 times less potent than morphine in volunteers. However, opioid adverse effects are still apparent, such as nausea, constipation, and dysphoria. Tramadol enhances the descending inhibitory systems in the spinal cord by inhibiting noradrenaline and serotonin reuptake. Analgesic efficacy of tramadol is reduced by concurrent administration of serotonin receptor antagonists, such as ondansetron. Uses of tramadol. Tramadol is used in treatment of acute and chronic pain. Tramadol improves analgesia and reduces morphine requirements after major surgery. Tramadol is contraindicated in patients receiving monoamine oxidase inhibitors, in patients with hepatic impairment due to reduced clearance, and in patients with end-stage renal failure. Adverse effects of tramadol includes dizziness, nausea, vomiting, respiratory depression, dry mouth, sweating, confusions and hallucinations, sedation, drug dependence and withdrawal. Tramadol may cause convulsions, especially in combination with other drugs known to reduce seizure threshold, such as tricyclic antidepressants and selective serotonin reuptake inhibitors. Naloxone can antagonize only 30% of the effects of tramadol. Dosage of tramadol. For normal release formulation, 50 to 100 mg orally, 4 to 6 hourly, up to 400 mg per day for short courses. For slow release formulation, 100 to 200 mg OD or BD. For combined preparation with paracetamol, such as Tramasep, 37.5 mg tramadol with 325 mg paracetamol, 1 to 2 tablets QID. For post-operative pain, 50 to 100 mg IM or IV, 4 to 6 hourly, up to 250 mg in divided doses as initial dose for post-operative pain, up to 600 mg per day. For patient-controlled analgesia, a typical regime is 10 to 20 mg boluses with a 5-minute lockout. Tramadol causes less nausea than morphine, however the degree of analgesia is inferior to that provided by PCA morphine. Dosage interval should be increased in the elderly and in patients with liver or renal impairment. Dosage requirements may increase in patients with reduced CYP2D6 activity as the metabolism of tramadol into its active compound O-desmethyltramadol is dependent on the cytochrome P450 system. Mixed opioid agonist-antagonists. Mechanism of action. These drugs have agonist effects at the KOP receptor and weak antagonist or partial agonist effects at the MOP receptor. Advantages. These drugs have the ability to produce analgesia with limited depression of ventilation. They have a ceiling effect for respiratory depression. They produce less euphoria than full MOP agonists and have lower potential to cause physical dependence. Nausea and vomiting are less common than morphine. Disadvantages. They have a ceiling effect for analgesia. They attenuate the efficacy of subsequently administered opioid agonists. Dysphoria and hallucinations are relatively common, but are less commonly seen with nalbuphine. Withdrawal effects may occur if given to patients taking MOP agonists. For pentazocine, side effects include sedation, dizziness, hallucinations, dysphoria, sweating, hypertension, tachycardia, and precipitation of withdrawal reactions in opioid addicts. Pentazocine may increase pulmonary and aortic blood pressure and myocardial oxygen demand. Its side effects has limited its popularity. These agents should be reserved for patients who are unable to tolerate a pure opioid agonist. Examples of mixed opioid agonist-antagonists. Pentazocine is given orally or parenterally. It is metabolized in the liver via conjugation to glucuronides. First-pass hepatic metabolism is extensive after oral administration. Excretion is via the kidneys. Half-life is 2 to 3 hours. Uses of pentazocine includes to relieve moderate to severe pain. It is useful for treatment of chronic pain when there is a high risk of physical dependence. Pentazocine has been used to reverse the respiratory depression caused by morphine or fentanyl while maintaining analgesia. Meptazinol has an unusual chemical structure. Route of administration, oral or IV. It is a partial MOP agonist and has central cholinergic activity. Potency: 100 mg of meptazinol is equivalent to 10 mg of morphine or 100 mg of pethidine. Meptazinol is used to treat moderate to severe pain. It is also used in labor analgesia. It may cause dysphoric effects in high doses. Increased nausea vomiting occurs compared with pethidine. Meptazinol does not cause euphoria, dysphoria, or severe respiratory depression. However, it does cause nausea, sedation, dizziness, and anticholinergic actions. The analgesic effects of meptazinol is almost completely reversible by naloxone. Dosage of meptazinol is 50 to 100 mg IV or IM 2 to 4 hourly as required, or 200 mg orally 3 to 6 hourly. Butorphanol. Compared with pentazocine, butorphanol's agonist effects are about 20 times greater. Its antagonist actions are 10 to 30 times greater. Butorphanol causes less dysphoria. This drug has been withdrawn in the UK in 1983. After IM injection, it is rapidly and almost completely absorbed. 2 to 3 mg IM produces analgesia and depression of ventilation, similar to 10 mg of morphine. Sedation, nausea, and diaphoresis are common side effects. Nalbuphine is an agonist of KOP receptors and partial antagonist of MOP receptors. Metabolism occurs in the liver, excretion in the urine. Half-life 5 hours. Onset for IV route is 2 to 3 minutes, for IM route is 15 minutes. Nalbuphine inhibits ascending pain pathways, thus altering responses to pain. It causes analgesia, respiratory depression, and sedation like morphine. It is used for pre-medication, during anesthesia, and for treatment of pain. Compared to morphine, nalbuphine has less side effects and has less maximal attainable analgesia. Compared to pentazocine, nalbuphine has less psychotomimetic effects. Nalorphine is a partial agonist at KOP and sigma receptors and is an antagonist at MOP receptors. It is no longer available. Dihydrocodeine. This is a synthetic opioid with a structure and pharmacokinetics similar to codeine. Preparations available includes immediate release and sustained release. It has similar potency to codeine. It is developed in the early 1900s. It is used for treatment of post-operative and chronic pain. There are very few clinical trials demonstrating its efficacy. It has marked antitussive effects. It has fewer side effects than morphine or pethidine at equivalent analgesic doses. It has significant abuse potential. Dihydrocodeine is commonly used in combination with paracetamol as co-didramol. Dosage is 30 mg orally or up to 50 mg subcutaneous or IM 4 to 6 hourly or 0.5 to 1 mg per kg in children. Loperamide is a MOP agonist that acts mainly in the myenteric plexus of large intestines. It has no analgesic activity. This is because it is extruded from the brain by P-glycoprotein. Loperamide is used to treat diarrhea as it inhibits peristalsis. The oral dose is 0.05 to 0.1 mg per kg, 8 to 12 hourly. Adult dose is typically 2 to 4 mg, 8 to 12 hourly. Maximum dose 4 mg 8 hourly or 0.4 mg per kg 8 hourly. Tapentadol. It consists of one molecule that has dual mechanism of action. Via MOP agonism, it is much more potent at the MOP receptor than Tramadol. It also has a strong action in inhibiting noradrenaline uptake in the spinal cord, activating alpha-2 adrenergic receptors in the spinal cord dorsal horn. Potency. Although the affinity of tapentadol for the MOP receptor is 50 times lower than that of morphine, due to the synergistic dual mechanism of action, tapentadol is able to produce potent analgesia. It is equianalgesic to oxycodone. Uses of tapentadol. It is used to treat moderate to severe acute pain. It is also used to treat chronic pain. By reactivation of descending inhibitory pathways, tapentadol produces analgesic effects in chronic neuropathic pain patients. Compared to tramadol, tapentadol is one molecule that has a dual mechanism of action. In contrast, tramadol is a racemic mixture of two enantiomers, with each enantiomer having a different mechanism of action. Unlike tramadol, tapentadol does not inhibit neuronal reuptake of serotonin, resulting in a lower incidence of nausea and vomiting. Tapentadol's lower affinity for the MOP receptor may limit undesirable side effects mediated by this receptor, such as gastrointestinal side effects. In contrast to tramadol, tramadol's main metabolite O-desmethyltramadol has high MOP receptor affinity. Cebranopadol. This is a synthetic opioid. It is an agonist at all four opioid receptors. It has highly potent agonist activity at nociceptin and other opioid receptors. It has anti-hyperalgesic effects due to its activity at NOP receptors. It causes less respiratory depression and abuse potential. Phase 2 of clinical development has been completed, demonstrating good efficacy across a broad range of preclinical pain models. It demonstrated good tolerability. For further details, kindly refer to the research done by Etorphine is an analog of thebaine. It is 1000 to 3000 times more potent than morphine, thus a small volume can fit into a dart when shooting large animals. It is used mainly in veterinary practice for analgesia and neurolab analgesia to immobilize large animals for trapping. It has very similar actions to morphine. Dipipanone is a potent opioid with a half-life of 3.5 hours. It is administered orally. It is marketed in combination with cyclizine. It produces morphine-like effects and psychosis. It is no longer recommended for the following reasons. No evidence to suggest that dipipanone cyclizine offers any additional clinical benefit or is superior to alternative opioids. It is a popular IV drug of abuse. It has high risk for physical and psychological dependency, and it has high cost. Dextropropoxyphene. This drug has been discontinued as it can cause serious toxicity to the heart, even when used at therapeutic doses, causing prolonged PR interval, widened QRS complex, and prolonged QT interval. It was used to treat mild pain via oral administration. Its active metabolite, norpropoxyphene, has convulsant actions. These are my references. Thank you.